orientation to where we are in relationship to the tumor and also to the vital structures. That helps to that improves the accuracy of tumor removal and also protect the vital structures so that the morbidity is much less at that point. And again, the latest one is the Da Vinci robot surgical system, which is to me the only indication, real indication in the head and neck is the oropharyngeal cancers. All the other things are all just for cosmetic reasons, for avoiding scarring gland. So the other most important thing is the working with other specialists like the neurosurgeon and the plastic surgeons who are able to find out new avenues to reach the tumors without injuring the vital structures, and also able to reconstruct the head and neck and the skull base so that will not lead to any morbidity. And also we work with the radiation oncologists, medical oncologists. All their need is input is needed to make the patient better end of the day. So in the past, the surgical options for reconstruction is very, very poor, and still we use this. It's not that we don't use it, but this should not be the only way to reconstruct the head and neck region. But it gives poor cosmesis, loss of function, and also it limits the tumor resection. These flaps will not reach the different parts of the head and neck and skull base, so that limits the surgeon. It's not removing it is very easy. We have to put it back together. That's the most important thing. So we have the wonderful reconstruction options now. We want skin for skin from the forearm, thigh, and also the skin, the bone, to the fibula flap, or we want the intestine for reconstructing the pharynx, we can use the jejunum. And I'm going to talk about only the surgical approaches here. I'm not going to talk about anything else. So I'll talk with the oral cavity. Now the reconstruction is aimed at not closing the hole in the mouth or closing the hole in the neck. We aim at improving the function also. So we have to improve the appearance so that the patient should be able to confidently move with others in the society, and also improve the function so that patient is able to eat and talk well with the rest of the people. The mandible gives a facial contour, and also it helps in opening and closing the mouth as chewing the food. And so what happens when you remove the mandible? So if you remove the one half of the lateral aspect of the mandible, does not give us significant deformity as far as the appearance is concerned. But when you look closer, if you do not reconstruct the lower jaw shifts towards the side of the resection, and even though there are teeth here, they don't meet each other, so it's totally becomes ineffective, and so the chewing food is very difficult. So we have to aim at reconstructing the jaw so that we retain the function of the mandible. So if you remove the central segment, if you do not reconstruct, the entire chin, it goes inside, gives a ugly deformity as well as the functional loss because of antical deformity. So this should be the side of the normal mandible, and the chin is gone inside. So it's just a case example to show how we do the reconstruction. Currently, not only currently being done is, this is a patient with a large tumor extending from the angle to the angle, and this is after tumor resection. We have used the fibula graft along with the skin paddle, fibula to give the patient the mandible, and also the skin paddle to line the skin defect. So this is the diagram where the skin paddle is designed based on the perforator coming to the paddle of skin. Then the fibula is removed, and this is cut into small chunks without injuring the blood supply to the fibula, and then that's reassembled in such a way that gives a facial contour, and can put the dental implants also the same sitting. So one of the problems is putting the dental implant in the same sitting is if the fibula fails, because it is not, there's always a 5% risk of flap failure. If the fibula fails, the dental implants also get waste. So the best option would be to put the dental implants as a second stage after the fibula is healed well. This is after complete healing. This is the skin pattern lining the gingiva. And this is the fully functional mandible. On the dental implant, the dentures are fixed, and they are fully fixed. You can open them out, chew, and the occlusion is not altered. So sometimes it's not easy to design or predict the shape of the mandible, especially when you have a large tumor like this. So the 3D image, the 3D reconstruction of the jaw helps in designing the implant, and that gives a reasonable shape using a 3D printer. So all we have to do is we give the CT scan, CT scan images to the person, and he will give a virtual design, show us the picture, see whether the shape is good or whether this is where we want the implant to go to. And once he say yes, then the implant is printed, custom made for this patient. So one, this makes life easier during surgery, it saves the time, and also gets the mandible exactly in the right place. So even you can reconstruct the joints. Sometimes we remove along with the condyle, and the reconstructed the titanium implant has to have a small socket, so that's designed with again with the 3D printer, and that can be fixed. So tongue is involved in speech, chewing, swallowing. It's a complex function, and that's just an example. This is a 6-year-old boy for aggressive fibromatosis. We resected the tongue and reconstructed with the anterolateral thigh flap. This is almost a total glossectomy, and so there's no point just putting the chunk of tissue there. So we have to reconstruct in such a way. We reconstruct each subunit of the oral cavity, like the floor of mouth, the tongue, all those things should be reconstructed. This is immediately probably a few days post-op. See, the floor of mouth is reconstructed with a different paddle, undersurface of the tongue is a different paddle, and the dorsum of the tongue is reconstructed with a different paddle. So the other one way to reconstruct is sometimes we use what's called gastro-omental flap. The greater curvature of the stomach is taken with the right gastroepiploic artery and vein, and the omentum is also taken. And this is the reconstructed tongue. One of the advantages is that the gastric mucosa secretes lots of mucus. And that's a boon to the patient, especially who has xerostomia after radiation. This is a patient from Myanmar who was done a long time ago. This is 2 weeks post-op. This is complete total glossectomy. So I'm not sure you can hear this. There will be some difference in pronouncing certain letters, but she is able to manage reasonably well, and she is drinking without any aspiration. This is 2 weeks post-op, and when we reconstruct the tongue, we do the laryngeal suspension. We bring the larynx up and anchor it to the mandible, so that physiologically, when the patient swallows, the larynx moves up, gets stuck underneath the tongue. So same thing we create by doing the laryngeal suspension. As far as the oropharynx, the tonsil CA, posterior tongue, and the surgery causes a lot. The earlier times, the surgery was the treatment. was done for this kind of warfarin tumors, and these are long procedures, need a tracheostomy, and results in a long functional and cosmetic defect and long-term hospitalization. So the radiotherapy was later introduced in the mid-20th century, and then that became the treatment of choice because that avoids all these the side effects of the surgery. Later, they introduced the chemotherapy along with that, so to improve the outcome. The chemoradiation is not without side effects. There is loss of taste, can cause xerostomia, almost the throat becomes like a paper, dry, and that causes difficulty in swallowing, case teeth, pain, and also the radiation dermatitis. This is a rare thing, and osteoradioid necrosis of the mandible. So the surgeon started thinking that whether we can do something about this so that we can avoid chemoradiation, at least in early tumors. So people started using the laser and also the robotic surgery and also the transport ultrasonic surgery to remove these tumors so that we can avoid the side effects of radiation. So the goal is to decrease the morbidity related to the open surgical procedure and also to decrease the swallowing dysfunction which is related to the chemoradiation. So that's the goal of the transoral robotic surgery. So basically you have to avoid the morbidity due to the surgical procedures and also to avoid chemoradiation. But you have to give chemoradiation for each and every case you do robotic surgery, then the purpose is lost. So because most of the time warfarin tumors, I find in my experience, they get cured with chemoradiation. The only thing is you want to do surgery to avoid the chemoradiation. So I think you must have seen about the surgical robots with different consoles, and the surgeon works in a different place, stay away from the patient's table. And the three arms are used. One is for the camera and the two other instrument arms. And this is a case example of mucophthalmic carcinoma of the posterior third of tongue. This is after robotic surgery. It's about 1 year post surgery. So far no records. And we didn't have to give radiation post surgery. We didn't have a tracheostomy. There's no scar involved, and speech and swallowing function is quite good. The other, that you need special instrument, equipment, lots of investment. But when the transoral ultrasonic surgery is, we're going to use the same instrument used by the laparoscopic surgeon. So this is much cost effective. But the robot has a definite distinct disadvantage because the tip of the instrument can go in rotate in 360 degrees, which we cannot do with the toes. This is an example of a radical tonsillectomy where you see a tonsil, and we have to resect the tonsil along with the superior constrictor muscle. So the incision is made at the level of the pterygomandibular raphe, quite lateral, and that divides the superior constrictor, and then tissue is dissected medially. This is the medial pterygoid muscle. You see the fibers, vertically oriented fibers there. There's a medial pterygoid muscle. This is the parapharyngeal fat, what you see there. This is the parapharyngeal fat, and the carotid artery lies deep to that. This is the styloglossus muscle. That's also divided. This is quite a simple procedure, so you don't need special equipment for this one. But posterior third tongue lesions is quite difficult with this one because the instrumentation will not be able to move the way we want it to move. Since they're using the harmonic scalpel, there's no bleeding there. So here it can cauterize the lingual artery with this bleeding. That's the style of process. It's quite a straightforward procedure. There's no reconstruction required. It's almost like tonsillectomy, so don't have to worry about it. If you do the neck dissection along with this one, then probably have to retain the submandibular salivary gland. So because that would to an extent block the saliva from going down. So these things can be the radical tonsillectomy, tongue-based resection, supraglottic partial laryngectomy is kind of done with this robot as well as with the torch. So the dean and others, they studied these cases, and they looked at how many percentage of patients may have retained gastrostomy after chemoradiation, open surgery, and robotic. And the chemoradiation, people who receive chemoradiation did better than the open procedure, and robotic surgery did extremely well as far as the getting rid of the gastrostomy tube within the 6 months. So potential benefits are less blood loss because we use the bipolar cautery or the harmonic scalpel to cauterize the vessels, and no tracheostomy is required most of the cases. But in supraglottic laryngectomy, you need to have the tracheostomy because you can, if it bleeds post-operatively, it can cause aspiration. And so this is mainly to eliminate the need for chemoradiation and the side effects associated with that one. The complication rates are less, and the functional outcome is good with this one. Now go to the nose and sinuses. For traditionally, what started with the ethmoid tumors going intracranially, the craniofacial resection, and the oblong resection of the entire ethmoid complex and the skull base. That's the aim of the procedure. For that, you need to have biconal incision and also lateral rhinotomy incision to access from above and below. This is the left-front craniotomy is done. The lateral rhinotomy and medial mastectomy is done. So from working from below and above, the tumor is removed, and then the defect in the skull base is reconstructed with the peripheral flap, and most of the time they're done. The post-operatively they do well, and this is not a significant morbidity because the incision goes behind the hairline so that scar is not seen. But retraction of the brain causes lots of problems because you're retracting the brain, which is not involved by the tumor. So that causes edema and contusion, and that can lead to loss of consciousness or seizures. So the aim here is to see whether we can avoid retracting the normal uninvolved brain. So that's what the endoscopic craniofacial resection is about. So the endoscopic skull base, in endoscopic skull base surgery, we resect the skull base bone, which is between the nasal cavity and the tumor, and the tumor is removed without touching the uninvolved brain. In fact, nothing but a craniotomy through the nose. So there are lots of different approaches for the skull base, endoscopic skull base approach. We want to talk about the transcriptiform approach for the ethmoid tumors. And this is a case example. It's a 50-year-old male, the recurrent carcinoma of the ethmoid post chemo radiation. The tumor is not getting into the orbit, it's displacing the periorbita here. And this is the frontal sinus is not involved, the sphenoid sinus is not involved, only retained secretion there. The blue line shows the level of the skull base. The tumor is going intracranially, but it's not involving the brain tissue as such. Just displacing. You see the CSF light going above the tumor there. In this one, we remove the ethmoid first. We will debulk the tumor. is the frontal sinus here, draft 3. And this is the orbital fibroblast with the small defects in the periorbit up here. The sphenoid sinus is here. The dura is incised little lateral to where the tumor is infiltrating it. This is the frontal lobe of the brain. So this is the tumor and this is the brain frontal lobe. So you have to separate the two. This is the olfactory bulb. On the right side is free. On the left side, when you dissect the olfactory bulb, you can see the tumor involving the olfactory bulb also. This thing here. Then the olfactory bulb is divided. This was the area of tumor infiltration. This is the posterior limit of resection, the dural resection. This is a large defect in the stuff base. This is the frontal sinus. That's the level of the stellar fascica there. You see the stellar here. And from laterally from orbit to orbit. We don't have the flap inside the nasal cavity because all the carotid flap is translucent because the tumor is involved there. So we use the fascia lata, tucked like the inlet graft into tympanoplasty, and the two layers on top of that other layer of the fascia lata was laid. So we'll go to the next topic. If you look at the middle skull base, there are two regions here. One is the medial one is the nasopharynx, and laterally you have the infratemporal fossa. And we're just going to talk about the tumors invading the infratemporal fossa. The primary tumors arising from the infratemporal fossa, malignancy are rare. Most of the time, the tumor goes from the maxillary antrum or from the oral cavity or from the nasopharynx. They cause severe pain and trismus is considered, whenever there's a trismus, because the involvement of thyroid muscle is considered inoperable. Because one, people are afraid of resecting this tumor because traditionally we've been told the thyroid plexus bleeding is uncontrollable and so people are a bit reluctant to do that. The other one is the reconstructive possibility. So the oblong resection of the entire infratemporal fossa, there's a large defect there. All these pedicle flaps will not reach and cover the area. So need a compartment resection for this. So this is the intercontinental infratemporal fossa along the ramus of the mandible, if necessary along the skull base is done. So the incision is as marked here for lower lip splitting incision for the lower cheek flap. And the upper cheek flap depends upon what you're going to do for the maxilla or where the tumor is coming from. If the maxilla is going to be involved or the orbit is involved, then just the incision accordingly. So the osteotomies are like here, the angle of the mandible. And depending upon the involvement, the entire maxilla, like a maxillectomy, or just remove the posterior half of the maxilla alone. So I'm just going to diagrammatically show how the compartment resection is done. And you do the osteotomy at the angle, and because the space limited at the level of skull base is very, very minimal. So if you divide without dividing it, if you struggle the skull base, it's very difficult to remove tissues, difficult to control the bleeding also. Once you divide the angle of the mandible and disarticulate the temporomandibular joint, then the whole thing moves down. It moves down the cell, probably in 2 to 3 millimeters of movement inferiorly gives enough exposure, and also you can drill out the skull piece with the greater wing of sphenoid, and that will give a good exposure to control the breathing. And then go along the greater curvature of the greater wing of the sphenoid and the subperiosteal. If the dissection is done along the subperiosteal plane, you don't come across the pterygoid plexus. They don't bleed much. And only thing is they will have the emissary veins at the level of the foraminal vein, then that can be controlled with the bipolar cautery or the surgical flow seal. There's so many options available now. So this is the left side. This is the nose. This is the upper cheek flap is raised. This is the lower cheek flap. This is the ramus of the mandible, condyle here, coronoid process here, zygomatic arch. It was in my initial days, so I used to remove the zygomatic arch to get a good access into the temporal fossa. So now I don't do it. So once divide the temporalis muscle, divide at the angle of the mandible, like here, also at the angle of the mandible, divide the temporalis of the temporal fossa, and then subperiosteal dissection along the skull base. After disarticulation, the temporomandibular joint. And if there is difficult to see, you can build a little bit of bone here, then good exposure to that region. So this is after complete dissection of compartment dissection of the infratemporal fossa. This is the greater wing of the sphenoid. This is the level of the foraminal veil, where you see the surgical is used to pack the emissary veins to stop the bleeding. This is another case showing the compartmental dissection of the infratemporal fossa along the greater wing of the sphenoid. That's the dura. And this is the greater wing of the sphenoid taken up along with the content of the infratemporal fossa. Another one, orbit, infratemporal fossa, and also the subtotal pedicectomy. So remote subtotal pedicectomy, sigmoid sinus is here. The sigmoid sinus becomes the IJV here, and then this is the optic nerve that was divided, and this is nasopharynx you see. Orbital filtration, maxillectomy, subtotal pedicectomy, infratemporal period. And this was done for carcinoma of the buccal mucosa. So what I'm trying to say is, so the infratemporal fossa need not be a frightening thing as long as you follow the right path. I think you should be able to dissect it without getting into a problem. And this is a patient who had CM maxilla, had radiotherapy, total maxillectomy had been done, and the Rosan palliative chemotherapy was done elsewhere. And if you see the scan, see that the orbit is fully involved. And this is the temporal dura that's also involved. The entire infratemporal fossa, tumor there going into the temporal fossa. So this was resected en bloc. Just with the orientation, the sphenoid sinus is here, nasopharynx is here, this is the temporal lobe, this is the frontal lobe. The dura is also excised. As I said before, the reconstruction is not possible, all these things cannot be done. So I owe all this to my reconstructive surgeons. And it's the anatomical type microvascular flap with 3 paddles. One is to line the nasal cavity, and one is to line the defect in the palate, the other one for the cheek. We use the bone grafts to do the facial contour. Extent of resection. This is almost 22 years post-op. He is doing exceptionally well. So if you look at the literature, one of the best papers by Dr. Shah in 2005, they had about 25 patients from 1996 to 2002 for a period of 7 years. And ovarian pathology like sarcoma, squamous cell carcinoma, adenoid carcinoma, and the 5-year disease-free survival was 41%. that is from 0% to 41%. And I have been doing this for the last 30 years, and more than 90 patients in the last 10 years, and most of them are salvaged post-radiation chemotherapy or recurrent tumors. And disease-free survival in 5 years is about 40%, almost same as the best practice. The nasopharynx, chemoradiation, the treatment of choice. Local 1/3 of the fail at the primary site, and re-radiation have been a treatment of choice for a very long time. Because the nasopharynx is considered an unresectable structure. Why? Because it's centrally located, surrounded by bony structures which are not involved by the tumor. If those structures are involved with the tumor, yes, we can dissect it along with the bone that's involved. So laterally you have the mandible, ramus, superior you have the cranial base, anterior you have the maxilla, posterior you have the vertebral column. You may have to break through one of these bones to reach this area. Traditional work, the loss of pioneers have done wonderful work. Fish in 1983 described the trans-temporal approach, and William Wei from Hong Kong in 1989 described the maxillary swing. Almost a similar period, Janaka described the facial translocation approach, which is a modification and modular approach of the maxillary swing. The trans-temporal approach is the infratemporal fossa type C approach. It gives a good access to both the nasopharynx, infratemporal fossa, and horizontal as well as the vertical petrous carotid artery. Disadvantage is it destroys the hearing and limited access to the contralateral nasopharynx. So this is a patient who had it's about 32 years ago. I'm not sure. Then 2001, that's post-chemo radiation, going up to the lower skull base. The tumor is seen involving the carotid artery here, carotid artery. So the resector not to resect. If there's no cross circulation to circular release in about 25% of the patient. So therefore, the stroke is a possibility if you do not know the cross circulation, and also the half of this can be fatal. So we need to know the circulation to the circular villus. So we do the abdominal balloon occlusion test, see there's a good circulation, make sure there's good cross circulation, there's no neurological differences during the procedure, and if so, we embolize, block the internal carotid artery, and then resect it during the carotid angiography, and then resect it during surgery. So I'll just describe what is done in a diagrammatic way with using this MRI, and then I'll show you the post-operative picture, then we'll understand. So we have post-oral incision and raise the skin flap, and do the subtotal petrosectomy. This is the sigmoid sinus, internal jugular vein, carotid artery. Subtotal petrosectomy. And then the important rule for the clearance, excision of the internal carotid artery, and then the nasopharyngectomy. So this was the plan of surgery, and this was achieved. This is the posterior end of the nasal septum. This is the contralateral eustachian tube, and this is the sigmoid sinus, and this is the area where we ligated the internal carotid artery and the septum. So the defect was reconsidered again with microvascular flap using rectus abdominis, and this is 4 years post-op. He did well, but after 4 years he developed the second primary, the piriform fossa, and we lost him to that one. So we talked about trans-temporal approach, and we talked about the facial translocation approach. So the tumor is at the back end of the nasopharynx, and there's no access. So we need to block resection, and we have to swing the maxilla without the nose and take it away from the tumor, resect the tumor, and put it back again together. So that's what the facial translocation or the maxillary swing approach is talking about. So maxillary, just a maxillary swing unilateral. or nasomaxillary swing the maxilla along with the nasal nose, external nose, or bilateral maxillary swing. The one thing we have to do is we have to do the pre-plating. We may find the osteotomy side and do the pre-plating so that when we put the maxilla back together, it fits exactly in the right position after removing the tumor. This is the orbital tract. This is the floor of the orbit here. And this is where the nasopharynx is. This is 2 weeks post-tract. We have remove the right tube and reading well. And so she's closing the eye because I want that through the inferior fornix of the conjunctiva to preserve the patient now to the orbital tract oculi, just to show that the orbital tract oculi is functioning well. So this is the nasomaxillary swing. This is adenocarcinoma of the nasopharynx, and this is the carotid artery, the carotid artery. And there's a fat vein between the carotid artery and the tumor. So after the nasomaxillary swing, tumor was resected. This is in almost 16 years ago. And he's doing well. Again, the incision is placed in such a way that the scar is not noticeable in an ugly way. I talked about the different ways of doing a splenectomy. And all these are associated with lots of morbidity depending upon the type of approach we made. Facial scar, trismus, palpal perforation, malocclusion, numbness over the cheek, loss of hearing, all this. And all these are due to the exposure we made, not from tumor resection. So these the exposure-related morbidities can be avoided by using endoscopic approach, but unfortunately we can use it only for small tumors, not for big tumors. In the endoscopic nasopharyngectomy, we remove the floor of the nasopharynx, which forms the roof of the floor of the sphenoid sinus forms the roof of the nasopharynx, and also the part of the clivus and the lateral wall of the eustachian cushion. This is the recurrent nasopharyngeal carcinoma. Picture is showing the reference there. This is a very, very small, tiny tumor. So to see the image here, you can see a small tumor in the photo rows in the middle here. Very tiny one. So I done the medial maxillectomy on this right side, septectomy, and raised the nasopharyngeal flap from the opposite side and left it in the left maxillary antrum for safekeeping. I'm doing wide sphenoidotomy here, stripping the soft tissues off the pterygoid plate. And slowly stripping soft tissue along the skull base here. Clivus. And then the pterygoid plate is drilled. This is eustachian tube being exposed here. Just trying to strip the soft tissue off the clivus there. Sometimes we use the monopolar concrete to basically soft tissue off the clivus and then drill the clivus. So that gives additional margin. You drill the bone. So that, and also you keep drilling the bone so that soft tissue also falls out of the bone. And this is the incision of the mucosa, contralateral side, posterior wall, and then coming through the lateral wall of the nasopharynx. That's using a monopolar concrete. I'm using the monopolar concrete to strip the soft tissue of the clivus, and the clivus also drilled to give additional bond. Just using the problator to cut the soft tissues lateral to the lateral aspect of the eustachian tube, and just dividing the cartilaginous eustachian tube from the bony eustachian tube here. And then the entire thing is dissected in block. all the resections are controlled with the folding section margins. This is post-op, no recurrence. And if you look at the literature, 5 year survival after re-irradiation is about 30%. And the salvage surgery almost double the 5 year survival rate. So definitely surgery should be the treatment of choice if possible. The larynx, I'm not going to talk about laryngectomy or laser, all this everybody knows. So only thing is sometimes very rarely we come across a patient with stromal recurrence, and patient with severe pain, difficulty swallowing, and the blood leads into the trachea, and it's a difficult problem to manage. And the season classified into 4 types. Type 3 and 4 are inferior or anterior to the trachea, and these can extend into the superior mediastinum and go around the vessels, so the outcome is poor with these tumors. But type 1 and type 2 are behind the posterior wall of the trachea or the tracheoesophageal groove, so those outcomes are better. So this is splitting the mandible here. Dissecting the superior mediastinum, and trachea is divided just above the innominate artery, and this is the cut end of the trachea here, and this is the left innominate vein, superior vena cava here, innominate artery, and it's down. We want to initially plan to do the jejunum, but the tumor was going down below the esophagus, which is the total spagectomy and the stomach. Then we use the pectoralis muscle to cover the vessels and also the trachea, so that the trachea will not, tube will not erode into the dominant artery. And the mediastinum is calcium here. So type 1 and 2 have the 5 year survival about 45%, and type 3 and 4 have a less than 90% chance of survival. So that's what the I talked about skull-based surgery in adults. Skull-based surgery in children is quite complex because the developing facial, craniofacial skeleton and neurovascular structures are cramped into a very tiny space, unique pathology, small-sized patients, and they don't tolerate blood loss during surgery. This is a girl with osteogenic sarcoma. We had about 6 cycles of chemotherapy, and the intensive is a tumor. And she has lost the vision because the tumor was stretching the optic nerve, completely lost the vision. And she had, I think one surgery has been attempted elsewhere before, and we used the same incision, the current bicoronal incision without any incision in the face, and with the incision of the superior and inferior fornix of the conjunctiva, and strip the soft tissue off the nasal bone and the frontal bone and off the tumor. This is the floor of the nasal bone. The entire thing was removed and blocked, and if you see the picture here, this is the nasal septum. This is the dura covering the frontal lobe, and this is the optic nerve is divided. This is the temporal lobe dura. And we used to preform the titanium mesh to give facial contour and also support the dura. And we use the fibula graft to give the facial contour. Otherwise, the cheek will go into the remove the maxilla. So this is the post-op picture. This is a young boy with rhabdomyosarcoma, a 2-year-old boy, and this is after 6 cycles of chemotherapy. After 6 cycles of chemotherapy, almost no response, and the tumor is infertile fossa going through the ear, and with a total picosectomy, the superficial lobe of the carotid is elevated off the facial nerve, and then with the subtotal picosectomy, condylectomy, and effective anti-aging, this is the facial nerve. And this is the close-up gastric. This is the post-op picture. We've got a good facial function. This is a 5-year-old sarcoma. 5 years old and on. She needs the reconstruction later because at the moment she's in a growing phase. We can't do anything. Whatever we do will not be sufficient. So once the facial growth is complete, probably attempt the reconstruction. So she came from Bangladesh and we couldn't afford, so with the crowdfunding we raised the money and did the surgery. So as I said, I will be repeatedly saying again and again, is the team approach. We gain from each person's expertise, and at the end of the day, we should be able to put the patient out of the table and off the hospital, and should be able to mix with the normal people who are eating and talking. And we should never forget, when we do surgery, we should never forget the compromise on orthodontical principles. Whenever possible, we use minimally invasive techniques like the endoscope, laser, robot, to reduce the morbidity. And we have to reconstruct in such a way to regain the facial function as well as the facial contour as well as regain the normal function. And not the least is the rehabilitation. It's also swallowing therapy, speech therapy, and counseling stuff. So if you guys want to look at the surgical videos, that's in my website, so you can see it. So I'll get you later. That's about it. So if you have any questions, thank you for patiently